what I want from you people as preceptees is that don't look at the volume of mutations, though I have tried to simplify it as much as possible. So just try to look at the concept. So the thing is, we are at the end of the beginning of this molecular era. So the information is coming. Some things are actually still not adopted, but they will be adopted in future. And these molecular findings need molecular technologies also. And unfortunately, these are very costly and they are not available in all the systems, at least not in India. And US also, it's limited where it is available. So based on those limitations, each newer classifications takes into account these findings. But yes, eventually most of the findings which you see here will come in our routine daily practice. So with that note, I think we can start. And of course, my topic is molecular pathogenesis and newer targets, but I will be talking more about molecular pathogenesis and leave the molecular targets to my clinical colleagues, though I will touch on few of them. Okay. So I'll make it very simple. So I'll be talking molecular of B cell lymphoma and T cell lymphoma. So in B cell lymphoma, I will be covering all these lymphomas mainly with some subtypes. So starting with diffuse large B cell lymphoma. So currently, what we are doing is we are using the morphology to diagnose this entity, and these are aggressive mature B cell lymphomas. And then there are some subtypes. I'll not get into that. And then of course you need to distinguish the more aggressive ones also on morphology, and then you need to find out the double hits and triple hits based, which is based on fish testing, the MIC BCL2 and BCL6. And then there are these wastebasket categories also. And of course, based on IHC, and I think Gaurav has not really covered, but yes, based on IST, we also try to classify it as the germinal central type and the activated B cell type. So this is the IHC paradigm which is used. For these diffuse large B cell lymphomas, CD10 is, if it is positive, then we do further IHC. And I will not get into this because I want to go for the molecular part. But then this, of course, is classified based on this. I just want you to get the concept of it. So, and this is a heterogeneous group of tumors, and historically this has been divided based on the cell of origin, and as I told earlier, germinal center B cell type and the activated B cell type. So how did this classification come? So just going to the roots. So these are basically transcriptomic based classifications, and what you see on IHC is basically a surrogate. So most of you are also medical oncologists here. So what happens, even in your breast cancer, you have ER, PR, HER2 testing for all your breast cancer patients. So what is that? That is also a surrogate for the transcriptomic analysis. So you do take lot of genes, maybe in breast it is 500, here also it's some 400 genes which are taken, and a category is defined. So you clinically, based on the prognosis, a category is defined. One category is GCB and the other is ABC. And since you can't do a transcriptomic analysis for all your DLBCL, so what you do is you use a surrogate, and that surrogate is your IHC, what is being used by the pathologist. So that is by the transcriptomic analysis. And similarly for your ERPR also, it's a surrogate for that transcriptomic analysis. So there are various ways of classifying these diffuse large B-cell lymphoma. One, as I told you, is by the transcriptomic analysis, for which the surrogate is IHC. Then there is it is defined by the genetic alterations, which we'll talk about, and also defined by the tumor microenvironment. So as Dr. Nupur rightly mentioned, that in the lymphoma, it is not only the cell, but the microenvironment is also important. So the classification is also different based on that. So first, coming to the transcriptomic analysis, as I told you, so this IHC based classification is a surrogate. So how much is the concordance with the actual transcriptomic analysis? The positive predictive value is of 87% for the GCB group and 73% for the non-GCB group. And the concordance with the gene transcription profiling, that is the transcriptomic analysis, is 86%. So it is 86% that it is concordant with the actual classification. And for breast cancer, the concordance is only 50%. So that's just to give you another thing. So these classifications, these are just surrogates. So you cannot just take them as gospel truth that, okay, this has been classified as GCB or ABC, that they are actually there. It may be slightly different in the actual transcriptomic analysis. And not only the Hans classification, the IHC, but there are also many other classifications based on IHC, like the modified Hans or the Choi. All of them are able to classify, but there still remains a heterogeneous group which does not match in all of them. So as I told you, so this is how the gene expression profiling looks like. So you see the expression of which gene goes up, which gene go down, and then you use statistical model to classify them into various groups based on the clinical prognosis. So all these classifications since time immemorial, the morphology or moderate or well or poorly differentiated, they all have been correlated with the prognosis. So we are trying to help the clinician make a diagnosis or predict a diagnosis. So that's the aim of all the classification. So yesterday we had the morphology, maybe now it's the morphology and molecular, and maybe tomorrow we have something else. Okay. So then coming to the next thing, defined by the another classification system defined by the genetic alteration, that is looking at the mutation. Earlier we were looking at the RNA level. Now we are looking at the DNA level at the genetic alterations. So this classification came when these two papers, so these two were the big papers which came, and there were many people classifying it. And you can look at this theragram. So there are many people classifying it, but more or less they all said the same thing. So there was this group, which is the MCD group, which had this MYD88 or CD79B mutations. Then there was this EZB group. Then there was this BN2 group, and these were named by different names, like BN2 was named by Notch 2 group or the C1 category by different groups. So, but they all had the same thing. So if you just look at them carefully, so if this is the genetic classification, that is the commonest group is your BN2 group, and then there is MCD group, and then there is EZB group, and the rarer ones are A53, ST2, and N1. And if comparing it with the transcriptomic analysis, your GCB and ABC groups, if we just have a look that all your MCD group patients are in the ABC group. So they are ABC, and for your BN2, there is partially some of the cells classified, the cases classified as ABC, some as GCB, and in your EZB, most of them classified as GCP, and your ST2, also most of them as GCP. So that's how these classifications are interlinked. So, and what about the prognosis? So, I told you many groups have given these genetic classification. So, if you just look at the genetic classification in the ABC patients, in the different cohorts who had given this classification, so clearly there is a winner. This BA2 group is prognostically performing better in all of them. And then there are other groups. And if you look at the GCB cases, clearly this group AZB is the worst performer, which you are seeing. So there are similarities in all of these groups, and more or less these are likely to be adopted, though presently WHO is not recommending adaptation of these groups, which is going into the detail of these because I feel they have lot of prognostic value and even the therapeutic value. So coming to the MCD group, which as I already mentioned has MYD 88, the classical mutation L265P. This is not solely limited to this diffuse large B cell lymphoma, but it is also seen in other cancers, which we will talk later. And it also has CD79B mutation. It activates the NF kappa B pathway, and there is also frequent deletion of CDKN2A, and it has BCL2, which is retained, and it has immune invasions. And just talking about drugs, so this polatuzumab is the anti-CD79B drug conjugate which is available. So there are drugs to based on this thing. So MCD type, your diffuse large B cell lymphoma, they are frequently arising in the immune privileged site. So just look at this figure. So this is the MCD type, and if you compare to the other immune privileged sites like your primary CNS or primary cutaneous lymphoma, they also have similar mutations. So what I'm trying to say here, if you can just get the messages, and I will show you for the other tumors as well. So today you are naming this type of lymphoma as this, but at the molecular level, the two names which may be so different are actually connected. So they may, to tomorrow you may have some absolutely different classification system putting them all together. So this is, they have in all of them, which one thing is common, they have immune evasion mechanism. So they have reduced antigen presentation with mutation in the MHC class 1 or TAP1 inactivations and PDL1 and PDL2. And another thing, so these ABC, diffuse large B cell lymphoma with BCR mutations, respond well to ibrutinib, especially if they have MYD88 mutations. So this is a study which compared the mutant CD79B patients with response to ibrutinib versus the wild. Definitely, the patients who had this mutation responded better, and they also compared MYD88 alone with to the wild performed better. But when both these mutations were present in the same patient, that is the MCD group, these patients performed far better on ibrutinib compared to the wild. So this is a group which needs to be recognized because this will do well on your ibrutinib therapy. So then the other group is BN2, where the Notch2 mutations are there. And if you just look at this figure, so this has mutations which are similar to your splenic marginal zone, nodal marginal zone lymphomas. So it is comparable to that. So right now, this is that group which has those mutation, and it also 72% of them have BCL6 translocations. Then the EZB group, which has obviously activation of EZH2 mutations, and there are several epigenetic regulators. And then again, they have a profile similar to your follicular lymphomas. So here you can see the mutation profile is similar to them. Then the ST2 mutation, they have SGK1 and TET2 mutation. Majority are again GCB type. And then they also are similar to group NLP, HL, and and the THRLBCL. So tomorrow it is quite possible that these come and they are grouped under one category because their mutations are quite similar. So then is the A53 group, which has TP53 mutations, and there are frequent chromosomal abnormality and other inactivation of beta-2 microglobulin. Then N1 group, which has not mutations, it has poor prognosis. And then this is a tool which is freely available. So if you can do the mutation profiling, the mutations have already been listed and they're given by the various cohorts, and then you feed your files in this tool, which is freely available by NCI. You can have my slides. You don't need to take pictures. And so this will classify the your diffuse large B cell lymphoma for you. Where does it actually stand? So you can have a prognostic assessment for that. So, and this is like a whole view to show you. This is the GCB type on IHC and ABC type. And under the GCB type are your EZB and your these ST2 types. And under your ABC are your MCD and your N1 type. And the double hit lymphomas, which we're doing on fish, are coming under your EZB type. And in fact, now with the new WHO classification, there is a controversy of double hit lymphomas also. So initially, in fact, all your BCL2 and BCL6 along with MYC were classified as double hit. But now MYC and BCL2 double hit is clearly a different category, and we are still not sure about the MYC BCL6 double hit. It still remains controversial, and on doing a transcriptomic analysis of both these categories, it's clearly seen that they have different expressions. So for now, you should know that that BCL2 and BCL6 double hit may not be the same, and maybe the one will do worse than the others. So this is again just to show you the same thing, that you have CLL mutations in the CLL or the genomic profile of CLL, and the N1 which is matching the marginal zone, and the BN2 which is matching, and your similarly the other groups. So these are cells. I think this was covered by Nupur in her slides, the how the cells evolve and in which stage the arrest occurs and the clonal proliferation occurs, and you can see how all of them are related. So tomorrow there, it may be quite possible that they are grouped into same categories, which are now distinct lymphomas. So then coming to defined by tumor environment, another classification. So this is still not evolved. We are still expecting more data. But what we know is that the tumor environment also has distinct signatures there. So there is a GC-like signature, there's mesenchymal signature, there's inflammatory signature, and there is immune depleted signature. So, with immunotherapy, so these things might become very important. These kind of signatures becomes very important. But yes, lot of data is coming. Another classification is the landscape of cellular ecosystems. So this is a AI based model where the single cells are actually classified, and they're put into these 9 subgroups, but the clinical significance right now we don't know. And of course, we are banking on more data, and as it comes, so these will be clinically classified into different groups. So that's where we are for diffuse large B cell lymphoma. So the phenotype, the genomics, and the microenvironment, all of them are important. In the microenvironment, gene expression profiling, the single cell immune profiling, and the spatial immune profiling. So this knowledge is coming, and this will together add up to give us maybe a new classification. Okay, and this thing, maybe this is slightly off the cuff, but this is like very close to my heart. So and there is going to be there are a lot of studies showing the role of liquid biopsy, the cell-free DNA in your diffuse large B cell and your follicular lymphoma. So MRD monitoring, which was just limited to CML, is going to come to, in fact, everything. So, and liquid biopsy is one tool which can be used. In fact, I personally recommend, like, if you are in an institution, if you have money, you should do histopath and molecular and liquid biopsy for all your tumors. It can give you so much wealth of information, which you will be surprised when you see it. Okay, then coming to the Burkitt or Burkitt-like lymphoma. So of course, 80 to 90% of Burkitt lymphomas have this MYC translocations, which is the hallmark, and it is usually the translocation with the is with the heavy chain, Ig heavy chain, but also the combination with the light chain kappa and lambda is possible. And what happens is the heavy chain, the gene MYC is as such doesn't really alter, but your enhancer part of the heavy chain comes near, and it makes the MYC express more. So MYC is a proliferation marker, and if it expresses more, so more proliferation, more tumor, and that's how it works. Okay, so besides MYC, there this translocation, there are other mutations which you can see in this outer circle, which are present in the Burkitt lymphoma. And not only the BRIC translocation, but BRIC MYC mutations are also very common in Burkitt lymphoma, along with TCF3, ID3, CCND3. So these are, I'm not going into the detail. You want my slides? I can, if you want, we can discuss it, like, because I know molecular can become very boring if you are like not clinically related to it. But yes, they are related, and these can cause, especially the CCND3 type mutations. These patients have high proliferation, and it can have a very lethal type of malignancy. And then there is another thing, terminology, Burkitt-like lymphoma with 11q aberration. Though on morphology, it does look like Burkitt lymphoma, but it is on genomic level absolutely different from your Burkitt lymphoma, and they have a favorable prognosis, and they have these gain and losses in the 11q region. And even on the genomic profiling, if you see, this is the molecular mutations for your Burkitt, and this is for your Burkitt-like 11q aberration. So there is hardly any overlap besides the GNA13 and DDX3X. So, and the mutations which were classical for your Burkitt's are not seen there. Then the classical Hodgkin lymphoma, I think a lot has been said that now we are clear that the Hodgkin lymphoma is a B cell, the cell is B cell origin. Earlier, because it was only expressing PAX5 and CD20 was not expressed, but now, and there were very few cells, and now we are able to isolate them and also sequence them, and we see that they also have your IgH heavy chain. So that's very pathognomic of your B cells. So they are having the B cell origin. And what about the mutations they have? So there are very happening tumors. So they have lot of 9p mutations, and which involves your PAX5 gene. That's why the PAX5 expression. Then your 9p24, where you have your PDL1 and PDL2. That's why your these expressions on IHC, and then there are other markers. Similarly, even your primary mediastinal large B cell lymphomas have similar molecular profile. They also have gains in 9p, like your Hodgkin lymphoma. So that's why they are in the differential diagnosis also. And then also there are some rearrangement like CIITA arrangement, which leads to the loss of the HLA and increase in the PDL1 and PDL2 expression. And these are also seen in the primary mediastinal large B cell lymphomas. And the key mutation pathways, I will not go into the details, is the lower arrows, red arrows are loss of function, and the green up arrows are gain of function. So mainly the pathways involved are the NF kappa B, the JAK-STAT pathway, and the immune modulation pathway. So based on these pathways, the drugs are also selected. So the drugs, the immune pathway, so you know which can be harbored. So if you go into the depth of these, so you will know that why a particular therapy works here. So then coming to the follicular lymphoma. So for follicular lymphoma, we all know that the translocation 14, 18 is pathognomonic, but minded this translocation may be present in 50% of the normal individuals also, and they will never get a follicular lymphoma. So what is that which causes follicular lymphoma is the subsequent addition of your other abnormalities which causes your follicular lymphoma. And with follicular lymphoma, again, the most common, the partner is IgH heavy chain. And this also there is lot of hypermutation, and which actually leads to uh, different clones which will make the BCL do positive on IHC. It's not always the same clone that you will have the positivity. So that's one thing the pathologist should know, that it may not be the same clone which will work every time. Okay, then again, the key mutation players are the chromatin modifying or the epigenetic regulators, which are very important, especially your EZH2, which I think most of you, I think yesterday we were talking also, these mutations are important. And of course, along with the other epigenetic modifiers like KMT2D, and then the transcription modifier and NF kappa V signaling genes are also involved. This is again just to show you the landscape. So what is important? Epigenetic regulators are very important, immune and the JAK-STAT pathway. So these are the epigenetic genes which are involved. Of course, your EZHE is almost 30 to 90%, but much more than them is KMT2D, which is 70 to 90%, and KMT2C. So another about the variants of follicular lymphoma, the duodenal type follicular lymphoma, they have BCL2 classification. The gene expression studies overlap with the marked lymphoma. They have a lower frequency of genetic abrasions compared to the nodal follicular lymphoma. The testicular follicular lymphoma, it actually lacks BCL2 translocation, and they are CD10 positive, and they have good prognosis. In situ follicular lymphoma has BCL2 translocations, and they have some genetic aberrations which are in the epigenetic modifiers. So this is about the pediatric follicular lymphoma. I'll just skip this. And the cutaneous follicular lymphoma also, there is systemic and the restricted. And if you do molecular profiling, you can pick up the cutaneous follicular lymphoma, which will become systemic because they have a peculiar kind of molecular profile. So that will be the advantage of doing a molecular profiling on this kind of patients. So, and then there is transformation of these follicular lymphomas into diffuse large B cell lymphoma. So, what causes them? There are additional mutations in the apoptosis, chromatin modeling, and DNA damage genes, which leads to these transformation. And if you can pick up these mutations, you will know which is the one which is going to transform into diffuse large B cell lymphoma. So these are the players: the anti-apoptotic, the immune modulator, and the DNA repair genes. Then yesterday there was a talk about this F follicular lymphoma international proliferative index, prognostic index. But then there is also available the M7 of this, so which includes 7 genes along with the clinical features. But it has been shown that it is not very good in differentiated between the lower and the higher, but it is good to differentiate the higher risk group. So if you use these 7 genes along with the clinical prognostic factors, so you can differentiate with the higher risk group into the very low bad and the bad. So which can be done. But again, there is a caveat to this. This is based on the treatment which you have given to the patient. It is R-CHOP or just rituximab. And in the patients who were just given rituximab and chemo-free therapy, there was hardly any benefit of using this 7 gene signature. So that has to be kept in mind. Then coming to the mental cell lymphomas, I know I'm getting very monotonous, but look, you have
No,
to
but
get the
we all are liking it actually.
you're
Please
like,
carry on. Yeah.
that thank you. That makes me give me the spirit to go on. Okay. So actually each of them you need to go in the depth. You have to start with lot of things. So because of the time, you have to limit yourself. So mantle cell lymphomas, as I think pointed by Gaurav, so they are mainly SOX11 and cyclin D1 positive, and this is the morphology. So this particular mutation, which you see the 1114, is also seen in multiple myeloma. If you just relate, so how are they different? So the same mutation is also there. So here, that is the most of the mutations here in your mantle cell lymphoma are in the precursor B cells, and the breakpoint is 1 kilobase region, and it is called the major translocation region. So this is the major translocation which is there. But in your multiple lymphoma, there are multiple places where the translocations can occur. So here, the commonest one again is that the CCND1 gene comes and combined with the IGH enhancers, and as it is an enhancer, it enhances the expression of CCND1. So that's how it works. So that, but there can be multiple breakpoints. So that can be there. So it can be differentiated. But mind it, if you are using just your break apart fish, that may not be a good modality to differentiate. You will need to do something like a sequencing based modality where you can know, okay, where exactly this has occurred. So that will be needed. So, as already mentioned, that of course, most of your cases will have this translocation, but then it can be with the heavy chain or the gamma or the light chain. And then there can also be CCND2 or even 3 translocations. And then again, there could be cryptic translocation insertion, which will be missed on your fish testing. So for that, again, you will need to do a whole exome or genome sequencing. So there are two main these mantle cell lymphomas. One is the conventional, and other is the non-nodal or the mantle cell lymphoma. And the conventional ones are the ones which are positive for SOX11. They are mostly aggressive. They start from the naive B cells, and they have lot of complex mutations, and they are unmutated. So in lymphomas, unmutated is the bad one. Mutated is like good, lots happening. Okay, and they are positive for your cyclin D1. And versus the non-nodal mantle cell, they are usually having a blood or bone marrow involvement, and they are negative for your SOX11 IHC, and they are mostly mutated. And this mutation part, how do we see? This is the same hypermutation which we see in the CLL. Okay, so mostly I think till now Sanger has been done for that, but actually NGS is a very good modality to see the level of clarity, and the clones you see on sequencing is far apart compared to what you see on Sanger sequencing. I think slowly everybody is shifting to that even for CLL. So that is good where you can, and you can use the same testing here also if you have a doubt clinically. So even on your gene expression profiling, clearly there were two groups which you can see.
So, you have 8 minutes more.
Oh yeah, I'll finish. Okay, and I will skip all this. Then TP53, of course, is a bad prognostic indicator, and marginal zone lymphomas. This is a diagnosis of exclusion, and there are many fusions which are present, and most of them are with the IGH. But there's only one, this BER C3 and MAL T1, which is present in GI and lung March lymphomas. And then there are, of course, many mutations, and then CLL, SLL. So this is important because this has been used in clinical practice right now. So you have different, earlier it was just based on fish testing where you were seeing the deletion in 13q and the trisomy in chromosome 12, the deletion in 11 chromosome where you are seeing the ATM gene and the BRIC, and this deletion in chromosome 17, we are looking for the TP53. But now NGS sequencing to include the mutation has also been added to this, and the grouping has been told, the prognostic grouping has been predicted, and you can clearly see that the patients who have TP53 or BRIC1 like disease, so they are the worst performing ones. And then the patients who have, this is the journal population, and then just below is the one who have just deletion 13, and then the normal. So what I'm trying to basically tell you, for CLL patients, you need to do three things in the diagnostic workup. So this is not will happen, this is already happening. And so you need to do the fish testing. You need to do the NGS sequencing of these genes, and of course, the hypermutation status of your these things. So they are prognostically very important, which you need to see. And these are, of course, the mutation. If you're making an NGS panel, you need to include the mutations of ibrutinib resistance in the NGS panel. If you're sending it for NGS somewhere, so that has to be included. So these are the resistant, and again, these are the mutations for conversion to Richter syndrome, which I will skip. And coming to the T cell lymphoma, so angioimmunoblastic lymphoma, I think I'll skip the clinical features. So, what is important for all T cell lymphoma are the epigenetic modifier gene mutations and T cell signaling machinery genes. So, these are common to all T cell lymphomas. Only the percentages vary, but they are same there. So, if you just look at it, the TET2 mutation 80%, the RHO-A mutation 41%, IDH2 and DNMT3A. If you have this kind of a set, you know, if you're not sure on IHC or anything, you do this kind of mutation, you will know that this is where the origin is coming from. So for row A, there is one mutation which is important, which is there in most of them, is the G17V mutation. So this is in the GTPase region. I will skip the rest. And then there are these TET2 mutation, and these are the epigenetic mutation DNMT3A. And if you remember, these are the mutations which you on IDH1 and 2 also. So these are mutations which you see in your AML also. And if you just go and I'll just skip the thing. So if you just go and trace it, so these are the mutations which are present in the clonal hematopoiesis. So these are present there also, and from there one either it becomes AITL on addition of further mutations, or it becomes a myeloid malignancy on based on additions of myeloid kind of mutation. So that's why we say, so if you are tracking doing MRD for AML, don't use these mutations, but these could be in the clonal hematopoiesis. So these mutations cannot be used, but you need to realize that they have a common origin. And about the IDH2, so in your AML, IDH2 and TET2 usually don't come together, but here it is IDH2, which is more common. There in AML, your IDH1 is more common, and these can occur synchronously. So that is different. And there are, of course, structural abnormalities. And the PTCL group NOS also on gene expression profiling is showing three groups. So you have a GATA and a TBX2 and an unclassifiable group, and the GATA group is clearly prognostically behaving very bad. So that is that group. So if you do those kind of things, you will find this thing. I'm just concentrating on the important things. And again, as I told you, all the T cell lymphomas will have these mutations. Only in the frequency of these mutations will vary. Your peripheral T cells will have TET2, DNMT, 3A, and Rho A mutations. And coming to the anaplastic large cell lymphomas, of course, they are ALK positive or ALK negative. And if they are ALK positive, so the commonest partner is NPM, which has a nuclear and diffuse cytoplasmic positivity, but there can be other partners also. And you can see the whole list of partners that can be available, and they will have different kind of IHC staining, and your pathologist has to be wise enough to pick up the thing, because all partners will not look the same. Okay, then coming to the ALK negative, uh, this thing, and as I was talking, so there are these, based on the profiling, it has been found that there are these three groups. If you see clinically behavior wise, the best is your ALK positive group. They are behaving the best. And then the DUS P22 rearrangement patients, they are also behaving very well. They're behaving quite close to your ALK positive patients. So that's why this rearrangement fish should be present in your armamentarium of your molecular person. They should have this. And then, of course, the TP63 group is the one which is behaving the worst. And this is the triple negative group, which is ALK negative, DUS P3 negative, and TP63 negative, which is somewhere intermediate between the DUS P22 and the P63 group. So you need to identify. And I was just referring to that case which Gaurav had shown. In that, P63 could have P63 could have acted as a surrogate. It has a 100% sensitivity, but it is not specific. So it could have helped you screen out the patients which could have been sent for fish testing. So that, since we don't have, so that would be there. So I am skipping the more details. So then we can, the primary cutaneous also, I think it has, you can see around DUS P22 rearrangement in 28% of the patients. And then there are copy number alterations. These were the mutations. So whenever you're looking, it's a journal thing about any tumor. So there are four things which you need to know. One is the DNA mutations at the DNA level. The RNA level is the expression, which gives you the transcriptomic analysis, and the copy number profile, which is usually done by your microarrays. Okay, your NGS usually doesn't give you such a good copy number, a global copy number, microarrays. But now we are also having optical genome mapping, which is coming, which is actually the next generation of cytogenetics. So it might make your microarray and fish slightly sideline. They will be available, like Sanger is available in the labs. So it will be like your NGS for this thing. For, I think the future would be you'll do a sequence NGS for your patients and a optical genome mapping, and then collate the findings and then have the whole thing. But yes, that is still far away. Only thing is, the all these talks are just priming you for what is coming. So and maybe using these things, because if there are some mutations, row A, which if you're, it's like a simple primer you can make in your lab and just put it and on the tissue, and you will know that okay, this is a T cell lymphoma. So thank you so much for your patience.